Okay, good afternoon or good morning, depending on what time you're listening to this. But this is going to be our lecture over Chapter 13, Disorders of Anxiety, Stress, and Trauma. I'm having to do this over the internet because I have some personal issues that I have to take care of Monday. So this will take place of that class on Monday, which should be scheduled Monday the 22nd. Um, so that will be our lectures for these. So it will be two chapters, like chapters 13 and I think chapters 14 that I will do separately, but it will be disorders of anxiety, stress, and trauma, as well as eating disorders and neurocognitive, it looks like. So anyways, we're going to start with this one and kind of move right along. So chapter 13. We're going to talk a little bit more in depth about anxiety. I've talked about anxiety before. We talked about it a little bit in the beginning of the class. But now we're going to dive into anxiety and the stages and some disorders and stuff that we have with that. Looking at your book, your readings are going to be pretty much the complete chapter of 13, so there's not going to be any breaking chapter 13 out because everything in there you probably need to read and is relevant. So just go ahead and be reading chapter 13. When we're talking about anxiety, it's universal. It's generally helpful response to life circumstances that produce stress. For most people, it subsides after anxiety producing situation resolves. It subsides after the anxiety producing situation resolves. So typically anxiety is very transient, very temporary. For the average person out there, the anxiety is not something that you encounter on a daily basis, and that it interferes with your daily functioning. Again, remember, that's when it becomes a disorder, when it interferes with the individual's ability to function. And it also is unhealthy. It has some biological responses that we're going to look at as we move along through this chapter. So there's a lot of issues on that. What I want you to focus on here is nurses encounter anxiety daily. And we do. We encounter it in ourselves. We encounter it in patients. We encounter it in our families, our students. We encounter it daily. So we need to understand what anxiety looks like, what we're doing with it, how to treat it, how to help the patient through that, and those type of things. So some theoretical foundations, and normally don't dive into this, but I kind of want you to understand where we've moved in with anxiety treatment now. Anxiety is subjective to the experience. It's going to be different from me. It's going to be different from you. It's going to be different from everybody. My anxious response or my anxiety response is not going to be the same as your all's. A disorder may develop, again, if anxiety is disproportionate to that stressor. And basically what that means is the disorder occurs, or an anxiety disorder occurs, when your anxiety is not proportionate to that stressor. So let's say you lose your dog. Something happens with your dog. And Lord knows I love my dogs just as much as I love my children, and I'm sure a lot of you all do. However, if something happens to that dog and you have an anxiety or an event that would be like if you lost your child, and you grieve for this dog for days and weeks and months, and it causes you to miss work and it causes you to do all this, that's disproportionate to the stressor. Just the loss of a dog should not cause you to have those issues. So that's when a disorder occurs. Some advances in neurosciences and brain imagings and genetics are shown in the Diagnostic and Statistical Manual for Mental Disorders, the new one that is out in 2013. Because prior to 2013, many of these disorders were just grouped together in a generalized anxiety type stress. But now we have divided those things out, looking at them individually because they each have their own little separate things. The biological domain is what I want you to look at and really focus on. It's called the general adaptation syndrome, and it's what everybody goes through when we have those stages when we have those things that we need to worry about. The first stage we go through is that alarm reaction. Your body's internal responses, your sympathetic nervous system is aroused. There's some release of cortisol and adrenaline and some other chemicals going on. It signals to the autonomic nervous system, and there's a release of epinephrine. This is that alarm state, worried, something shocked me, something scared me. It's that startle, that something that has happened. And the external responses that we normally see in our body is your body is mobilized. It's moving, it's ready, it's on edge. Then we have the stage of resistance. This is the body continues to defend itself and tries to repair what damage is suffered. It continues to adapt. It's that fight or flight mechanism. Do I run? Do I leave? Do I fight? Do I stay? The body's adapting at functioning at a much lower optimal level. And if the body is able to adapt, the process or the problem resolves itself at this stage, and the individual does not go into the next stage. So this is somebody that deals with anxiety adaptively, deals with it, knows how to deal with it, knows how to function, and they come out on the other end and they're perfectly, I don't want to say okay, but they have dealt with the stressor and dealt with the anxiety. Now, if the person doesn't adapt at this point, then we move into what we call the stage of exhaustion. This is the body's total expenditure of energy. It goes a total use of every source that it has. It's no longer able to adapt or function adequately. Vital sign system tends to shut down, and illness and sometimes even death can occur from this stage of exhaustion. Emotional disorders, you can have migraines, hallucinations may develop, and again, death may occur at this point because the body is just totally wore out. You can read of that in a little bit more detail on page 243 in your book if you want to. The next slide kind of shows you it in a time and stress resistance type thing. So it kind of gives you an idea. You see the introduction, we're kind of trucking along there in the middle. And then there's the introduction to the stressor right here. And then the alarm stage. And then your body shoots up and it tries to fix it. Okay, you're startled. It comes up. Okay, this is our resistance. We're fight or flight. We're trying to fight it. We're trying to work on it. And then it either resolves itself and we deal with it adaptably, or there's that stage of exhaustion to where it just your body totally gives out. So it's kind of just the little view of it. The psychological domain, this is how you handle it mentally, and we do that through defense mechanisms. And there is a bunch of defense mechanisms that I really want you to focus on. And I have a chart here in the power slides or the PowerPoints that we'll go through here in just a second. But this is how you handle stress. This is how you handle that anxiety. Strategies that is used by an individual when experiencing a threat to the ego or that the ego cannot handle. So this is how you deal with it. Denial, falsification, distortion of reality, or some ways that people deal with anxiety. They help the individual cope with reality and maintain that self-image. And healthy individuals use it for temporary problem solving. Okay, temporary. Again, you're dealing with it adaptively, you're working through those problems, and you come out on the other side with the problem resolved. If you deal with it inadaptively or maladaptively, that's when we see that stage of exhaustion. So let's look at some of these. And I think these are in your book. I have them here in the PowerPoint slides, but they're also in your book on page 246, table 13.4, as you can see here. So let's just look at a few of these. You needed to be able to read through these and kind of have an idea. Here's a good definition. Here's a good example. The way you can understand these, because I will ask you some of these defense mechanisms on the test. So you need to understand, what is this person using? How are they using? Is it a good defensive mechanism? Is it a bad defensive mechanism? Compensation, making up for a perceived or real inability by focusing on another area and becoming proficient. And this could be conscious or unconscious. So let's look at the example the book gives. A 16-year-old boy is not good at sports. He strives to get top grades in his class and becomes a member of the school's honor system. So that's the way that he has dealt with the anxiety of not being a good sport. He compensates and becomes proficient in another area. Here's denial, avoiding, ignoring, or rejecting a real situation and the feelings associated with it. The example your book gives: a man tells his wife that he wants a divorce. The wife responds by saying all couples have difficulty and that she is sure he will feel differently tomorrow. That's another way to cope. It's another way to deal with problems and anxiety and stress, but you can look at the two differences here. This could be a good incident. Oops, sorry guys. This is a bad one. So, not all defense mechanisms are good. Not all defense mechanisms are bad. This here is a good one. This here is a bad one. So you can look through those and see. And as you're reading through them, know which ones are good and which one's bad. Humor, emphasizing ironic or amusing aspects of conflict or a stressor. Here's an example. The nurse with cold hands comments, "Cold hands but warm heart," before taking care of a patient. So that's another way. So that's a good one. So you can look through them and go over them. Here's some more. And again, like I said, they're in your book. So just read over them, read these definitions, and then read these examples and make sure that you can understand what they are, because I'm not going to sit here and read them to you. I think you can do that on your own. Okay, so now let's look at the levels of anxiety, because there is different levels and you need to understand those because you're going to run into them every day that you're working. Because again, we deal with anxiety on a daily basis. These are also listed in a chart in your book on page 245. So if you want to look at those, you can. If you do charts better than PowerPoints, but I also have them included here in the PowerPoints as well. Paplow's levels of severity is what we normally go by: mild, moderate, severe, and panic. Categories: normal anxiety, acute anxiety. Normal anxiety helps the individual to be more alert, thinking clearly, and I think if you remember back to the first couple of days of class, I talked about this, where a little bit of anxiety is a good thing. A little bit of anxiety is a motivator, and that's why that's there. It's a normal anxious behavior to things going on. Then we have an acute or a state of anxiety. This is normally temporary, heightened apprehension and tension, nervousness and worry. This is an acute stage of anxiety where something's going on and that anxious need has kicked in. And then we can also look at it in categories. So we can look at it in categories of normal, anxious, acute. Then we also have categories of chronic anxiety. Chronic anxiety is long-lasting. It's a condition, part of the individual's personality over time. So this person continues with anxiety. These are people that are on long-acting medications to control it. So it's just a condition or a state that this person remains in. It's also more debilitating because it's putting a lot of stressing on that body. If you remember our little chart or our stages that we talked about, these patients never really resolve, and they stay in that heightened level of anxiousness where there's at risk for that level of exhaustion. So we have to really monitor people with chronic anxiety really well. They have trouble performing at work, they have trouble in relationships and with their immune systems and other biological systems of their body because of that continued heightened state. This is also in your book on page 245. This kind of gives you the symptoms that we might see in relation to the anxiety levels. So here's the mild anxiety level. People normally at this level are restless, irritable, increased motivation. Remember me talking about how anxiety can be good because it can be a motivating factor. However, when we move up the line, here's moderate anxiety. We're starting to see some issues here with our body, our physical responses as our body that can be tiring, that can be overtaxing depending on what's going on. We have discomfort. We have an increase in heart rate, an increase in just the tension in our muscles, sweating, increased respiratory rate, increased restlessness, increased rate of speech. So you can see just by looking at these physical activities how much more taxing it is on our body. And if we move up to the severe level or level 3, again, we're increasing even more, increasing more taxing efforts on our body. You just have that ultimate desire to release the anxiety. Dizziness, diarrhea, feeling of dread, headache, hyperventilation, insomnia, nausea, palpitations, tachycardia, trembling, urinary frequency, total focus on self. This is just totally taxing that body to the point of exhaustion. And then if we get into that panic 4, again, look at these physical symptoms that we're seeing: delusions, hallucinations, diaphoresis, dilated pupils, labeled breathing, palpitations. So you can read through these and see. When we get up into this, our body is just at its max limit in dealing with things. Anxiety and trauma-related disorders. Remember, distress, suffering from anxiety, can be as painful as physical distress. The anxious and the worry and all that comes along with anxiety and trauma-related disorders can be as painful as a physical ailment. It's characterized by psychological and somatic manifestations of anxiety when we're talking about disorders. Obsessive compulsive disorders fall under this anxiety and trauma-related disorders, as well as PTSD. They all fall under this area now. Anxiety disorders. So let's look at them in general. In general, there's a prevalence of about 15 to 20% of adults will experience at least one anxiety disorder in their lifetime. So that's a pretty good number. The median onset for these, 11 years, early in age. So, there's a lot of kids suffer anxiety disorders earlier on in life, and we're starting to see that now. Often with additional anxiety disorder diagnosis, there's normally a comorbid condition. So there's normally something that follows that anxiety disorder, such as depression or substance abuse. So they normally go hand in hand when we're looking at that. So the first anxiety disorder I want to focus on or want you to look at is separation anxiety disorder. It's the excessive fear related to separation from one's home, loved one, or caregivers. This is one of those that's mostly seen in children. It normally is developmentally inappropriate. It ranges from somatic to refusal to participate in certain activities, and it must persist 4 or more weeks in children and adolescents, 6 months in adults. This is a persistent and excessive worry about losing a major attachment figure or about possible harm to them, such as illness or injury. Persistent and excessive worry about experiencing an untold event, such as getting lost, being kidnapped, something along that lines. Refusal to go out or away from home or school because of that fear of separation that they're seeing. Reluctance about being alone or without a major attachment, or refusal to sleep away from home or to go to sleep without being near a major attachment figure. They can have repeated nightmares involving the theme of separation, as well as repeated complaints of physical symptoms such as headaches, stomach aches, nausea, and vomiting when separated from whatever attachment that these kids and adults are seeing. Remember, it's 4 or more weeks in children and adults, 6 months, or children and adolescents, and 6 months in adults. Another one that you'll see that falls into anxiety and disorders is also what we call selective mutism. Refusal or withholding of speech in situations in which speech is expected, despite speaking in other situations. Needs to be present for about 1 month. It interferes with educational and occupational achievements. And it's not due to lack of knowledge, comfort with spoken language itself. It's mainly due to the anxiety or the anxious feeling that the patient's having. This is two examples that we've seen with the new DSM-5 that came out in 2013, because separation anxiety and selective mutism used just to be disorders among childhood and adolescents, but we have seen these show up in the adult population, so now it is addressed on both sides. Then we have specific phobias. When we're talking about specific phobias, the individual has a marked fear or anxiety about the specific object or situation or event, and it either directs exposure to an stressor or the anticipation of exposure almost always triggers an anxiety response. It must be excessive in nature, though, in the patient's culture without proportion to the actual danger. This is somebody who has an unrealistic fear of something, and then when they have a tip or changes to be or chance to be exposed to that phobia or that fear, then their reaction to that is just totally unfounded in relation to what's going on. Let's say exposure to snakes, because that's the one thing that comes into my mind. I have a fear of snakes and rats and all that wonderful good stuff. But, it doesn't cause me to have a panic attack with the thought of seeing a snake. What would be wrong is if I had the thought of seeing the snake and then I totally refused to go outside my house because of that snake. So that's totally disproportional to the actual danger. It's normally comorbid with other phobias, and of course this one occurs mostly in women more than it does in men. Social anxiety disorder. This is formerly known as social phobia, so they've changed the name that we see now. This is a marked fear or anxiety about a social situation where there is potential for embarrassment or scrutiny by others. Social phobias or social anxiety disorder. This is the getting up and talking in front of people, talking in a group, and you withdraw from that, and you don't do that because you're afraid of the embarrassment or the scrutiny that comes along with being in front of people. Now remember, you got to take the cultural differences out of that, such as in Japan and Korea, distress may arise if the individual blushes, makes eye contact, or becomes aware of offending others by having body odor. That's a cultural difference. There's a high rate of social phobias among individuals having relatives with this disorder. The onset of phobias normally occur about the age of 13. Then we have panic disorder. Again, this falls under the big umbrella of anxiety disorder. Onset usually between adolescence and mid-30s. This is a recurrent, unexpected panic attack followed with 1 month of either or both persistent concerns about having additional panic attacks or significant change in behavior related to those attacks. Panic attacks normally last for a discrete period of time and involve a period of intense fear and discomfort, which the individual experiences doom. The dread of doom is coming along. Normally, the symptoms that are involved with panic disorder are palpitations, sweating, trembling, shaking, shortness of breath, feelings of choking, chest pain, nausea, vomiting, derealization, which is a feeling of unreality, depersonalization, which is a feeling of being detached from oneself, and fear of loss of control, going crazy. Um, Normally, when associated with a psychiatric disorder, panic attacks signal a greater symptom of severity and for risk of suicidal ideation. So we have to be um, really in tune to that. And typically, again, panic attack involves at least 4 of these symptoms. They don't have to have all of them, but when we're looking at somebody and they're exhibiting about 4 of these, then yes, that's the sign of a panic attack is probably happening. Agoraphobia. Agoraphobia is fear of situations in which escape could be difficult. A lot of people think of agoraphobia of just fear of going outside, but that's not necessarily it. Agoraphobia is fear of situations in which escape would be very difficult. Typically in 2 or more of the following spaces: public transportation, open spaces, shops, theaters, cinemas, standing in line and being crowded, or being outside of the home. That's what a lot of people think agoraphobia is, but it's really just that fear of being unable to escape a situation. Median onset with this is about 20 years of age. It's seen in as twice as many females and males, and about 5% is what we see with the prevalence. 1-year prevalence is about 5% of the population. When we're looking at this, key symptoms of generalized anxiety disorder, that's the next one that I want to get into. And this is the one that you're going to see the most. This is the one that most everybody gets diagnosed with when we're having those anxiety disorders. So here's just some key symptoms if we're talking about just a generalized anxiety disorder. They're restless, they're tired, inability to concentrate, they're irritable, muscle tension, and sleep disturbances. So we're seeing this circle of things, and then that excessive worry is causing these things. Then we're looking at what we call generalized anxiety disorder. Generalized anxiety disorder is excessive worry in 2 or more domains. For example, family, health, finances, school, or work, more days than not over a period of 3 months. So you worry more days than not over a period of 90 days in one of these domains. 1 or more of the following behaviors are normally seen: avoidance, anxiety and worry are associated with restlessness, feeling of edge, muscle tension, the ones that we talked about on the previous slide. And patients with generalized anxiety disorder report significant distress or impairment in functioning of their social and occupational and other activities of their life. Again, 1 or more of the following behaviors must be seen: avoidance in activities with possible negative outcomes, time and effort preparing for activities with possible negative outcomes, procrastination in behaviors, decisions or making due to worry, or decision making due to the worries, and repetitive seeking reassurance out about those worries. So they're always seeking, they're putting off making decisions because of the behaviors. They're putting a lot of time and effort into things because they're anxious about it, or they just avoid the situation overall. This is rarely seen in children. Again, median onset with this is about 30 years of age. So this is older in life. And a lot of times this is associated with just life events that's going on, things that's going on in their life. It can occur at any point in life, but the age of onset is typically about 30 years of age. And a lifetime risk of about 9%. Other types of anxiety disorders you might see: substance-induced anxiety disorders, and that's just resulting from the physiological effects of a medication or a substance that the person has ingested. Anxiety disorder due to another medical condition, which can be happening. Maybe they're having tests, diagnosed with cancer or whatever reason that it may be, but it's due to another medical condition. And anxiety disorder not otherwise specified. So otherwise, they just really don't know what causes it. Then we have the obsessive compulsive and related disorders. So again, remember, we're still under this umbrella of anxiety Stress and trauma. This is new to the DSM-5 in 2013. Previously included with anxiety disorders, but now it kind of has its own little umbrella. Lifetime prevalence of obsessive compulsive disorders is 2.3%, hoarding 2 to 5%, and skin picking disorders is 2 to 5.4%. Again, they've created their own little area for these disorders because they have broken them out into 3 disorders of their own. They've broken them out into their own little disorders basically because researchers have found a distinct neural circuit that differentiates these obsessive compulsive disorders from other anxiety disorders. Obsessive compulsive disorders, body dysmorphic disorders, and hoarding disorders are all described here and kind of fall under this general category. So let's look at obsessive compulsive disorder, or OCD. A lot of people will say, I think I have this, or my husband has this or that. Nurses, you think some nurses have this, but basically what it is you have an obsession or compulsive tendencies. You doesn't have the disorder. Remember, in order to have a disorder, it has to impair their daily life or their daily functioning. When it's a disorder, it's a recurrent obsession, compulsion, so persistent that they take an unreasonable amount of time. For example, more than 1 hour each day, or it causes significant distress or impairment. It's causing some sort of issue with their daily functioning. Then we have obsessions, recurrent and persistent thoughts, urges, or images causing significant stress, such as contamination from germs. So remember, the obsession is normally the thought, the compulsion is normally the behavior. So you got to remember to keep those two separated. Compulsions, again, the repetitive behavior or mental acts the individual feels driven to perform. Ego dystonic, those with uncomfortable sense of self, and their ego syntonic, which is the individual's comfortable with self in relation to how they perceived in the world. Frequent obsessions and compulsions you'll see here. To be considered either an obsession or compulsion, the item below needs to occur, again, more than 1 hour a day or cause significant distress. And some obsessions that you see here causing harm or being harmed, contamination of illness, making mistakes, losing things, it's those thoughts, those images, impulses. The compulsion, remember, are the behaviors, the repetitive behaviors, the repetitive mental acts, praying, counting, repeating words. Even though those are behaviors, they're still considered mental acts. They're physically doing something. So make sure you understand that the compulsion is an act, where the obsession is a thought. Some OCD or obsessive compulsive related disorders is trichotillomania, which is pulling hair out by the roots. Skin picking, there's substance abuse, obsessive compulsive disorder, and then just basically obsessive compulsive or related disorder due to medical conditions, and then OCD unspecific otherwise. There's also body dysmorphic disorder. This has moved into this anxiety category. This used to be a somatic symptom disorder, but we now look at it under these obsessive compulsive and related disorders. This is repetitive behaviors or mental acts in response to preoccupation with a perceived flaw or physical experience not visible to others. For example, mirror checking, excessive grooming, reassurance seeking, comparing appearance of that of others. They think there's a flaw. They think there's something wrong with them. So they're all the time trying to fix it, all the time trying to check on it. That's their obsession and their compulsion. Their obsession is, they're stuck on that thought that there's a flaw. The compulsion is these active behaviors that they are doing. the patient might actually have a flaw, but the flaw might be very, very minimal into the way that they look at that patient. So in other words, maybe a patient's nose is slightly crooked where they broke it when they were 7 years old. Somebody with body dysmorphic disorder is going to see this flaw and perceive it to be much more worse than what it actually is. So the nose is going to be physically broken, sitting sideways on their nose in their eyes, in that thought that they have, that obsession that they have. And then their compulsion is going to be a behavior in order to check on that problem. So that's body dysmorphic disorder. Then we have hoarding disorder, and I know you've all watched Hoarding on TV, and if you haven't, it's a pretty neat show. You need to probably pick that up. But this is continued difficulty discarding or parting with possessions due to perceived need to save the item. And like I said, just a version of Hoarders on TV. It's all you need to do to watch to understand this. These patients never throw away anything. They basically hoard and keep everything to the point to where living spaces become unfit for use. Again, that's when it becomes a disorder. Symptoms normally emerge in childhood, but normally aren't debilitating till later on in life. And the distress is significant when they have to throw something away. They just panic attack driven when something has to be thrown away. Another new category that was new to the DSM-5 in 2013 is trauma and stressor related disorders. And this is where we're going to see things like post-traumatic stress, reactive attachment disorder, and those things. Those kind of fall under these trauma and stress related because they're due to trauma or some sort of stress. Onset of symptoms are clearly linked to a traumatic or stressful event. Again, prevalence in the United States, about 7 to 8% of the population. Basically 5.2 million adults have been diagnosed. And reactive attachment disorder and dishabituated social engagement disorder are a whole lot more rare. In this subset of these disorders of anxiety, stress, and trauma, you're basically going to see the PTSD is the biggest one that you'll see diagnosed here. But let's talk about the others. Reactive attachment disorder. This is normally driven in children. They do not seek comfort when distressed, barely responsive to efforts to comfort for them. There's limited positive effect. They do not seek out that contact between adult and child. Fearfulness is also seen. Again, they don't have that normal interaction between caregiver. Despite an apparent stressor, there's nothing there. This is normally due to a history of persistent neglect and repeated changes in caregivers. We see this a lot in children who go into the foster care system at a very early age. Also with the orphans and some of the homes that we see in Eastern Europe and those type of things where kids do not get that comforting that they need, that bonding that they need at a younger age, or they're neglected at a younger age, then they cannot make that attachment. They cannot make an attachment to seek that help out. So therefore they have that reactive attachment disorder. There is disinhibited social engagement disorder. Characterized by pathogenic care described in RAD, same things, same characteristics as we see in the reactive attachment disorder. Children with this disorder rarely engage with unfamiliar adults, typically using language and behaviors that are outside cultural norms and familiarity. These children tend to wander from caregiver without seeking permission, even in unfamiliar settings. They often will go willingly with strangers. Nurses caring for children with histories of neglect and foster care should be aware that patients associated with this disease may also persist once the child is placed in an appropriate care setting. So this, they don't care. They just wander from one person to the other. It's not that they have an attachment disorder. It's just total social engagement is not there. Then the one that you're going to see the most, and the one that you need to focus on the most, is post-traumatic stress disorder, PTSD. These normally, again, rears itself at the exposure of a traumatic event, which can be death, threat of death, serious injury, or sexual violence. With the highest rate in this being seen normally with people who witness murder, natural disaster, and of course combat-driven veterans. It's in children, there's rape, childhood physical abuse may also result in PTSD depending on the level of both of those. The symptoms of intrusion, distressing memories, dreams, marked distress at occurrences that mimic or that are associated with the event, and flashbacks. There's different diagnosing criteria for children. So if you're in the working with the children population, there is some difference there. The highest rates for PTSD are seen in individuals who witness someone being badly injured. Immigrants from areas of social disturbances and civil conflict also might have some PTSD things as well. When we're looking at these, for men, it's normally rape, combat exposure, childhood neglect, and childhood physical abuse are what triggers PTSD. And in females, there's rape, sexual molestation, physical attack, being threatened with a weapon, and childhood physical abuse as well. When I'm talking about the symptoms of intrusion on this, just think intrusion. They are intruding into a person's life, either by intrusive dreams, intrusive nightmares, intrusive events that mimic the event, or just basically an intrusive flashback. Sleep disturbances and self-destructive behavior are also seen, as well as an aggression is very common. Flashbacks, when you hear the term flashback, it's a dissociative reaction in which the individual feels or acts as if the traumatic event is recurring all over again. So you will see the flashbacks in these people. PTSD can occur at any age. The diagnosing criteria is different for children. It is discussed in your book on page 254. You don't really need to focus on that. But it basically says, although it acknowledges that children experience many of the same symptoms in adult, the DSM-5 recognizes that other symptoms may be manifested in children, including the headaches, stomach aches, and some of those symptoms that we see a lot of times. There's then in this category also is an acute stress disorder. In that, the symptoms normally last for 3 days or up to a month after exposure to a traumatic event. Significant distress, impairment in social, occupational, and other functioning. Remember, it's not a disorder if it doesn't do that. And with acute stress disorder, the symptoms are very similar to PTSD, as well as hypervigilance. You'll see that, irritability, difficulty concentrating, and sleep disturbances. The difference between PTSD and acute stress disorder is acute stress disorder is time limited. You normally only see this for about 4 weeks. PTSD, the person lives with through the lifetime. So that's the difference between those. Then we have adjustment disorder. These are symptoms that occur within 3 months of onset of a stressor, but not normally longer than 6 months. Stressors not as severe as those seen in PTSD. So these are not as severe as issues as we can see in there. Clinicians should normally specify the subtype because it's normally related to something else. We're having an adjustment disorder related to depression. You're having an adjustment disorder related to anxiety or disturbance of contact, or it can be mixed, or it can be unspecified. So adjustment disorder is an anxious or stress related disorder where you're having to adjust to something. Okay, it's not as a severe life-changing event as you would see with a PTSD. However, you do have some of the same symptoms of PTSD, but again, it's very time limited, 3 months from onset of the stressor, but no longer than 6. And you're normally associated with some other symptom, again, such as one of these that's listed here. To treat these, we do a little bit of collaborative care. It's a combination of psychotherapy and medication is typically the most effective. You don't jump straight to that medication as with any medical or mental disease. Medication is not normally your first line of treatment. Failure of treatment may occur when the patient does not continue the treatment for a significant of time. Again, it's something that they have to continue on with as far as the anti-anxiety, antidepressant medications that they're taking. The biggest thing with this that we like to focus on with any anxious patient, and you have to educate them on this, is start low and go slow. We want to start on their medications on a very low dose, and as we increase them, we want to do that slowly. Again, with the patients, you want to encourage them to start with little things and go slowly increasing to the bigger things. Equal efficiency among different pharmacotherapies does not exist. One does not work like the other, nor does one work as well as the other when we're talking about psychopharmacology. There's no way to predict a patient's response rate. There's no way to determine if a patient's going to do better on one than the other. And when you're talking with patients about the starting of psychopharmacology, especially related to anxiety and stressors, you need to understand that the medications that they take, most of them do have addictive qualities to those. So we need to make sure that we address the indications, the side effects, and the alternatives that are possible. Some other medications out there are possible, as well as symptoms that may reoccur if they start on the medication and the medication is discontinued appropriately for any certain reason. Some of the medications that we use to treat these anxiety and stress disorders is we don't jump to those benzodiazepines right out of the bat. Remember, benzodiazepines are short treatment. They're not used for long-term maintenance of these medications, or of these symptoms. It's usually only used in the short time, just to get them under control. What we'd like to use for people with generalized anxiety disorder and some OCD and those type things are basically your SSRIs or your SNRIs. They're effective and they have a lack of those addictive qualities. What you have to remember with SSRIs and SNRIs is it normally takes 2 to 4 weeks to become fully active. Whereas if they give a benzodiazepine, that anti-anxiety kicks in and they have immediate relief. So you have to make sure the patient understands that I'm giving you something to help it work long term, whereas those benzodiazepines work short term. Now you can use a benzodiazepine and use it until we have effective treatment with the non-benzodiazepine treatments, and that can be perfectly okay, but you do have to remember there is some addictive quality to those as well. If you look on page 256 in your book, and you need to get that out or write these pages down so that way you can understand, the benzodiazepines is the first what you see there. Not really going to ask you specific medications. You just need to understand that these are benzodiazepines, and that's the word that you will see associated with these nursing considerations that you see. And that's how I want you to study this chart. I want you to look at the medications under the benzodiazepines and understand that for benzodiazepines, there's these nursing considerations if you look for all analytics. Same thing goes for SSRIs. If you see the SSRI, the next thing down, it says for all SSRI, provide education regarding these. Nursing interventions for all SSRIs, nursing interventions for MAOIs. That's how I want you to study this chart on page 256. So make sure that you look at that and understand the nursing implications that are associated with just these groups of medications. I'm going to give you a few here. When we're talking about MAOIs, they're rarely used, and I think I mentioned that back in chapter 3, because they have potential to have a hypertensive crisis if mixed with any medication containing thiramine. And thiramine is found in aged cheese, red wine, some birth control pills, some pain relief pills, cold allergy medications, herbal supplements. So MAOIs have a lot of drug-to-drug and drug-to-food interactions, so we have to be very careful with those. And we don't use those very often. And also we don't use those in combination with SSRIs because they can produce a serotonin syndrome. If we're looking at those anti-anxiety and sedative hypnotic medications or the benzodiazepines, remember they have a big, huge potential for addiction. They need to be prescribed only for short periods of time and used to help control anxiety issues once they get home. Short-acting patients with sleep onset insomnia, but no daytime anxiety, and slower rate of clearance in older adults. So you have to keep that under mind when you're using those benzodiazepines as well. When we're talking about the non-benzodiazepine, there's buspirone. It's used to treat generalized anxiety disorder. Again, takes 4 weeks for it to be effective, but however, it doesn't produce a withdrawal. There's no addictive qualities if we're using that medication. It can cause dizziness, headaches, and nausea, but also it is non-sedative. We can use beta blockers. What do beta blockers do? When you're looking at beta blockers, you're thinking, well, that's a cardiac drug. How in the world would I use that for anxiety disorder? But what does anxiety produce? Anxiety produces rapid heart rate, rapid respiratory rate. It causes everything to be keyed up. Well, what does beta blockers do? They lower heart rate. So they have a tendency to be able to lower those feelings and lower that heart rate in order to reduce those signs and symptoms of anxiety disorder. A lot of time we only use these beta blockers when it's somebody with a normal anxiety that's having just a little bit of problems. I have actually seen beta blockers prescribed to nursing students before they take nursing exams. It takes just enough of the edge off for the patient to be able to perform, such as giving a speech or flying an airplane. Some therapy that is used for anxiety and trauma-related disorders is basically cognitive behavioral therapy. Remember when I'm talking about CBT, the cognitive changes the way the patient thinks, the behavioral therapy changes the way the person behaves. It is the main form of treatment for anxiety disorder. You can be done in individual or group therapy. You also can be used in combination with medication. And there are certain types of CBT that's used for post-traumatic stress disorder to reduce severity of the response triggers. But you don't really need to worry about the different types. Just understand it's cognitive behavioral therapy that we use the most. And here's a chart, again on page 258 in your book. Some examples of cognitive behavioral therapy disorders, therapy for disorders. And you can see the type of disorder here as well as the therapy that will be going on. Some complementary and alternative therapies, which we can do, and we talked about that back in lectures last week. Exercise lower stress levels and can reduce endorphins, and it can increase social interaction, provide confidence, and provide distractions. There's also relaxation techniques that help deal with anxiety, such as yoga, meditation, progressive relaxation. All those are complementary and alternative medicines. Breathing techniques: breathe in for 4, hold for 2, breathe out for 4, teaching that person to calm down and get control of things. Some herbal supplements that can be used: chamomile, we talked a little bit about that back I think in chapter 3's, ginkgo biloba, vitamin B, important production. Vitamin B's or B vitamins are important for production of neurotransmitters. So there's things that we can use as far as that goes. But now, as far as a nursing thing, what are we going to do? How are we going to work with these patients now that you kind of understand what the disease is and what's going on? The biggest thing nurses do is to help identify what a patient sees as the stressor and help them relieve it. Identifying the source of that anxiety may not be possible, but we want to work through that. Anxiety is contagious in nature. So, you want to make sure you contain the environment by speaking low and slow. Self-awareness is important about what's going on, and use of that deliberate nursing process to work through these problems. When we're dealing with somebody with anxiety and trauma related, we got to look at an assessment. Remember, we always have to assess first, and we always assess for safety first. Once you have that out of the way, you do your physical assessment. When you're doing that, you should remain calm. Use simple and clear phrases, because remember, once a patient's anxiety level peaks, they're no longer thinking for themselves. They can barely ask you to brush their teeth, much less ask you what exactly precipitated their admission to the hospital. Provide information that the patient needs to lower anxiety level, and use of body language. Observe those vital signs, the demeanor, the facial expression, the body movements, voice behaviors, thoughts, context of conversation, and level of anxiety. All of those point to how that patient is dealing with the problem. In the interview, you want to assess for somatic complaints, ask about social activities, what they like to do, how they like to do it, how do you handle stress, what's going on, looking for the spiritual concerns, and if we need to call a pastor in, or if they have somebody on the way, or maybe they're not religious at all. You want to assess for environmental changes, as well as rating scales may also be helpful to establish a mutual understanding. We want to look at the differences among initial and relapse recovery and rehabilitation phases. In that initial or relapse, the patient has a high level of anxiety and is in need of concrete directions. If a patient is suffering from high levels of anxiety, they have already reached the point to where they've got to have some help. And we want to focus on what has brought them here. What have we got to that point? Recovery patients able to learn about triggers and may help strategies avoiding relapse. So maybe they will learn some strategies to help avoid them before they go in the next time. A rehabilitation patient copes with and avoids triggers and promotes health. Diagnosing and planning, some common nursing diagnosis, and remember, this is not an all-inclusive list, so you can look through these. Sleep pattern disturbance, anxiety, fear, coping, and effectiveness, fatigue. What you want to do, though, is prioritize nursing diagnoses. Most successful when patients and nurse work together to figure out, hey, what is the most important thing that I want to do to get out of this? Determine the diagnosis most relevant to the patient. It helps the patient buy into the care plan, and it's going to be more likely that the patient will have success with related to what we want to do. Make sure when we're planning goals, we want to consider if that patient's capable of developing a care plan and capable of working through this care plan. Assess the patient's what's going on, what the patient stated is most distressing. Try to look at, finding the cause. If we can find the cause, then we can help the patient work through those. Articulate and address specific and really realistic measurable goals. So make sure they have to be realistic, measurable, and the patient can do them. And remember those 5 domains I talked about in the beginning. Consider involving all of those, because they will be needing those. Learning needs and abilities incorporated into plans. Make sure you educate this patient about what they need, what they learned, what their abilities are. For example, information about sleep hygiene and keeping a sleep log if needed, if sleep disturbance is identified. So just make sure you educate that patient on what they need to do and what they'll see, what they can expect. You revise the care plan during recovery and rehabilitation. Support the patient's work towards their goal. Also support the patient's temporary relapse to old patterns. Doesn't necessarily mean they won't make it back to help. We just have to give them support to make that better. Interventions according to the patient's ability to concentrate. Patient's family support for plan of care. That's very important. As well as incorporate the patient's life story, occupational needs, and other circumstances. So this is what the patient's going to be doing. So we have to make sure the patient can do that. Interventions are different for every level of anxiety. You're definitely not going to treat somebody who's in a panic level of anxiety with the same interventions that you treat somebody who is just in a general state of anxiety at a mild level. So you got to be able to read between and what's going on with that patient and decipher by that by asking questions and listening. Those are really important. Help the patient establish goals once they are less anxious. And here's nursing interventions. It's another really good table. Kind of puts it all in a nutshell. It's also in your book. It's table 1311. Trying to figure out what page that's on for you while I'm sitting here. It's on page 264. And again, it breaks it out into mild levels, the moderate levels, and it tells you here's what the patient's perceiving, here's a good teaching learning, and here's some interventions that we can do. And it takes it all the way through panic. So make sure you read through that chart. Primary, secondary, and tertiary interventions. Remember, you need to understand the three. If you don't understand the three levels, then go back and review those. But here's the primary: reduce the risk of occurrence of anxiety or escalation to unhealthy and chronic levels. Secondary is early intervention and treatment, and tertiary is post-intervention education and looking for risks. You always want to educate. They need to understand the triggers, what brought the symptoms on, what they were looking for, and encourage those positive sleep habits. Need to look at those factors that influence their stress, patient's failure to disclose, the nurse's self-care, and minimizing the risk for reoccurrence. Questions that you gotta answer even though they sound silly and you're like, really? What triggers the patient's anxiety? And they're probably going to look at you and say, I have no clue what it is. We need to focus on questions again to stop the reoccurrence. What should the patient do first? Noticing the reoccurrence of symptoms. Who's the patient's support system? What can we do to help them? And of course, we always have to evaluate our care plan, determining whether our goals worked, how well the patient adhered to the care plan, and if the patient needs reassurance and reminders. Frequency and nature of changes as the patient progresses, more frequency at onset and then annual rehabilitation phase. They are always working through this. Change in one domain may not put a patient at risk, but they all should be reviewed. Everybody has to be acknowledged at some point. We have to acknowledge the patient's pain, even if it's a high level of stress is unwarranted. Patients just want to feel listened to and not heard. They want to know you're going to do something about it. And they must have some form of hope. Meet immediate needs of this patient, help the patient regain self-esteem, and note a positive observation and strengths. Okay, that's basically it for chapter 13. Again, you need to read the whole chapter. I would strongly suggest reading the care plans that's in the book, as well as doing the practice questions and the critical thinking exercises. I think those will help you understand and work through the questions that you have to do with this chapter. If you have any questions, email me and I will be in touch.